Welcome, everyone, to today's webinar, Revenue Cycle Predictions for the Post-COVID Healthcare System. I am Daniel Guest with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our moderator, Carol Zindler. Carol leads the client services team at Flywire. She's passionate about assembling and aligning strong teams to create and deliver solutions that positively impact the evolution of U.S. healthcare. Carol has over 20 years of experience leading customer-facing teams from early stages to mature SaaS healthcare organizations. At this time, I am pleased to turn the floor over to Carol to begin today's presentation.
Thanks, Daniel. Hey, everyone. This is Carol Zindler, VP of Client Services at Flywire. I'm super excited to be hosting today's webinar. If you're not familiar with Flywire, we're a high-growth vertical payments company trusted by organizations around the world to deliver on their clients' most important moments. Flywire elevates the patient financial experience by empowering providers and patients to engage, interact, and settle balances on mutual terms. Flywire's responsive payment solution leverages predictive analytics to automate and tailor each financial interaction to the patient's ability to pay. This increases patient satisfaction and optimizes financial performance. We have two amazing panelists that will share their insights and vision related to COVID-19 today. I'd like to introduce Mike Maruli. He is the Senior Director of Revenue Cycle Services at Hurley Medical Center in Flint, Michigan. Mike has full management responsibilities over revenue cycle operations for both hospital and professional services. He's spent over 35 years managing multiple patient accounting operations, and he has led successful accounts receivable reduction efforts, system conversions, and several process improvement initiatives. Mike has been a valuable and long-term colleague and collaborator in patient financial engagement and strategies and initiatives. Welcome, Mike. Acacia Holmes is our second panelist, and she's the System Director of Patient Financial Services for Munson Healthcare based in Traverse City, Michigan, which is composed of 9 hospitals across northern Michigan. In her role, Acacia has responsibility over patient billing, cash posting, customer service, financial assistance, and counseling. Acacia is a driving force at Munson and has a passion for delivering revenue integrity and amazing experiences to both her staff and her patients. Thanks for joining, Acacia. Before we dive into today's conversation, I wanted to set the stage. Alrighty, so even before COVID-19, patients were experiencing and hospitals were already working to address the affordability issue. Almost 50% of consumers can't pay a $400 medical bill. So if you think about you're at the grocery store, half the people there cannot pay a $400 medical bill. And this data is before COVID. So it's a serious situation. We know that there's been about a 25% increase in deductibles over the past 5 years, which accounts for about 30% of net patient revenue and a bigger burden, of course, on the patient and ultimately the provider. 9 out of 10 consumers want to know what they owe up front. And in another survey, we learned that about 90% of healthcare consumers would like to be offered payment plans up front. And unlike, as you guys know, unlike many consumer purchases, healthcare expenses are often unplanned and unavoidable. So payment plans offer relief, but they too must be affordable. So when you think about if you can only afford a $400 bill for half the population, you have to really consider the amount of a payment plan that is affordable. So providers really need to address these challenges. They need to address them strategically, and there's a number of things that we see that really need to be avoided. So things that don't work, one-size-fits-all payment options, confusing paper statements, hard to use patient portals with low adoption. I think we've learned if you build it, they may not come. Unaffordable payment plan terms. And so again, when you're dealing with a population that really has limited financial means, you need to consider what level of payment plan you offer. If it's too high, it's not going to be paid, nor will the bill be paid. As the affordability crisis is eroding collectability, we need to be responsive to these challenges and address the needs of the patient as the payer. And we have to be proactive and leverage technology and communication methods to address the patient needs in terms of their financial experience. So we just need to be thoughtful and attentive to that patient financial experience. And as we think about patients as consumers for the long term, they've given hospitals kind of a pass in terms of their expectations with technology and that consumer experience. But those expectations are changing. We're seeing that COVID-19 is really contributing to acceleration of that change. Access and affordability addressed in a modern way is really our job collectively together. So at a time of great pressure that we're under, like COVID-19, it really can be a time for great transformation. So we're excited to have so many folks joining this webinar and engage in this topic. And I really think of it as something that we're solving together. Okay, so, our two panelists today are from the state of Michigan, and I'm sure that we've all been watching, the national numbers and, what has been happening related to COVID-19. I'm going to dive a bit into the state of Michigan just to set the stage for what our providers are experiencing. So state of Michigan has a population of about 10 million people. It's a stunningly beautiful place, miles of pristine lakeshore, and of course, home to the automotive industry in Detroit, or in the Detroit region. Michigan has had more than its share of economic woes. The auto industry manufacturing downturn has really had lasting effects. Mike will share some insights on that. Detroit has been one of the hotbeds of COVID-19, and other parts of the states are having a more moderate onset. So much like how we want to address patient needs, I think the state government of Michigan has found that a one-size-fits-all approach to COVID is super challenging, and they recently rolled out a more regional-specific plan and guidelines for the state addressing the various needs. So I think we all know that this is very complicated. At a high level, over 50,000 cases with, sadly and tragically, about 5,000 individuals losing their lives due to COVID-19. It's a sobering statistic. Michigan has seen a rise in unemployment of 1.7 million people, and this puts an additional burden on the state and impacts healthcare benefits. The CARES Act expanded unemployment coverage for self-employed, for contractors, for gig workers, et cetera, and then also increased the unemployment benefits in both the amount of the benefit and the length of the benefit. We'll need to keep an eye on the uninsured rate at about 5% now. I think it'll be super interesting to see how the ACA marketplace adjusts or what other solutions may come to surface with this kind of new normal, as I do air quotes, that we're in right now. So with the added downturn of manufacturing in Michigan and then a yet to be determined impact on tourism in northern Michigan, I think our panels both have a really interesting perspective on this crisis. They're two very different organizations, and they'll tell you about their healthcare systems, but the challenges are different, but yet in many ways similar. So the way that we decided to frame up discussion, and hopefully you'll find it engaging and helpful, is to talk about how we're going to rally around people, processes, and strategies to address the challenges and really co-create and redefine our future. I feel that this time is exhausting, it's scary, it's exhilarating, kind of all at the same time. But there's no doubt that this work is really meaningful, and I'm just excited to have so many folks engaged and that we've got these amazing panelists. All right, so I wanted to share some data that we dug into to also set the stage here. We pulled some data from March 1st to date, and what we can see is that there's a significant reduction in patient visits and in collections. And this is not specific to our two panelists, this is across our Flywire patient base. So these reductions are not surprising given the reduction in scheduled procedures and the fear and the financial uncertainty of many of the healthcare consumers. We've seen an increase in payment plan creation and an increase in self-service payments. So we can see through this data that patients are shifting their behaviors under the current conditions. And at this moment, and I guess I would say always, it's really important to have the right tools in place for your patients and for your teams. I think it's super important to have engaged and collaborative partners as what I think of as your extended team, so that team of vendors. And at Flywire, we're really working to adapt our technology and strategies to the changing needs of our clients. So we've tried to provide our clients with meaningful data and information so they can see what's happening and make better informed decisions. So I feel that the best part of our purpose at Flywire is really co-creating the future with our amazing clients and impacting the lives of the patients as we do it. So with that, I think that we are ready to kick off our panel discussion. So let me, what we're going to do here is we'll have Mike and Acacia set the stage for each of their organizations and give you some background and some of the struggles that brought them up and wins that brought them up to the point of COVID, and then we'll dive into at the start of this crisis. So Mike, I am going to hand it over to you to talk a bit about Hurley Medical Center.
Thank you very much, Carol. It's a pleasure to be with everybody this afternoon. Thank you for letting me be a part of the presentation. I thought initially in terms of what Hurley is all about, I thought there are some key statistics that I wanted to share with everybody today. Number one is you may be able to tell from the picture, Hurley has been around for quite some time. Founded in 1908, Hurley's been there for about 112 years, located in the downtown, near the downtown Flint area. We are a 440-bed level 1 trauma center. We are probably one of the lone independent hospitals still remaining in the state of Michigan. We are a safety net hospital, and we are owned by the city of Flint. Another key point that I wanted to mention about Hurley is that we are a highly unionized workforce. We have over 10 unions, one of those unions representing our clerical revenue cycle staff. So we are intimately involved with our unions in terms of making sure that everything runs as they expect and as we expect. As far as the payer mix, as you can probably imagine, being in the city of Flint and the financial struggles that the city faces, we are 45% Medicaid. We are 32% Medicare. So between the two government-funded programs, we are 77%. Blue Cross makes up 13% of our payer mix, commercial, auto, work comp 9%, and self-pay 1%. A little bit of small details regarding the Flint demographics. Flint at one time in the 1970s had a population of over 190,000 citizens. At that time, General Motors had 80,000 employees in the city of Flint. Today, the city of Flint population is 96,000, and the General Motors population of an estimated employees is probably less than 6,000 staff members or employees right now. The median household income for the city of Flint is $27,700 in comparison to Detroit. And Detroit is at $29,500. So it gives you a little sense as to the median income of the city of Flint and some of the struggles that we have. I think a couple key statistics that I thought would really be important for everybody to know as we get into the presentation. 30% of the households in Flint do not have computers, as compared to 15% in the Detroit market. 58% of the households have no internet, and the same percentage for Detroit. And lastly, persons in poverty in Flint, 40%, as compared to Detroit, 36% in the city of Detroit. So it kind of gives you a little sense as to the demographics and the struggles of the city of Flint. Thank you.
Awesome. Okay, so Acacia, I am going to hand it over to you to talk a bit about Munson Healthcare.
Thanks, Carol. Hi, everyone. I'm Acacia Holmes from Munson Healthcare in northern Michigan. We really have grown from what started as a small system with our flagship hospital of Munson Medical Center in Traverse City, Michigan, which was founded back in 1925, to now a 9-hospital system serving all of northern Michigan and including provider offices as well as home health and hospice services. In 2015, Munson Healthcare acquired Cadillac and Grayling from the Trinity Healthcare System, and since then have also acquired hospitals in Charlevoix, Manistee, and Gaylord to create our new Munson Healthcare System. Pre-COVID, right now we would really be preparing for the summer influx of festivals and tourists to our region and trying to get staffing levels, adapt to that new volume. Currently, though, with the COVID pandemic, we're really trying to find that sweet spot of a surge that we have yet to experience, opening up some of our elective ancillary services, and then also just expected lower levels of tourism from what we've seen historically. And as Carol mentioned, the Michigan governor is really taking a regional approach to reopening our state, which in the Traverse City region is expected to start happening on Friday. So that's a new focus for us and just trying to figure out the new normal for healthcare in northern Michigan.
Terrific. Thank you, Acacia. Okay, so now we've created just a bit of a structure to share the story of the first 20 days, what the teams were seeing and what the initial strategy is. And so we'll kind of bounce back and forth between panelists. But for this one, Mike Muerley, I think we'll let you take away. What happened in those first 20 days?
Well, not unlike what everybody else is experiencing, a lot of uncertainty, number one. I believe that Hurley really started to see the impacts, as most organizations did, sometime in February, where our volumes started to take a reduction or a decline. Really saw that significantly occur in March, obviously, with the increase in the pandemic. So obviously the significant volume reduction started. One of the things that we found really quickly in terms of needs was computer system report. And I think most organizations can probably give a lot of kudos and credit to their IT departments, and I would do the same. There was a lot of information that was needed immediately in terms of how we manage our COVID population. So the computer system actions that were needed really kind of stepped up from our IT support team. We were obviously scrambling to address information demands. Our clinicians, our physicians, our mental health therapists, our PT, our OT therapists, our administration. There was a lot of information that we needed to manage in a quick period of time. So that was something that really we saw quite heavily in the first 20 days. What we also saw, and again, most organizations probably went down the same path, is our clinical teams began focusing on how we were going to serve our patients. And that word telemedicine really became a common word in our hospital during that period of time. This was something that we had done briefly in the past, but obviously it was stepped up pretty significantly come March, when the need for telemedicine and serving our patients started to really become a reality. We had a lot of uncertainty with our payers. The responses that we saw from the payers was somewhat inconsistent, and I do have to say that no fault to theirs. I think as most all of us would recognize, this was the first time for all of us in dealing with this type of pandemic in terms of the quick reaction time that was needed. So again, no fault of the payers, but the reality was inconsistent direction. You know, things were changing, guidelines were changing by the day, by the hour, so it was really difficult for revenue cycle and even the organization as a whole to react to the constant quick changes that were being made relative to guidelines and things that we needed to kind of make sure things rolled forward from a financial standpoint. You know, we needed to identify financial impact. You know, we were holding claims, waiting direction from payers. We had invalid claims that probably went out the door before we actually realized that the direction that we submitted was not probably what the payers had requested. So we were very interested in cash flow impacts in terms of what was going on with our COVID population. And then to top that off, we obviously started to see staffing anxieties in terms of what was going on within the office. Unlike some of the other revenue cycle operations around the country, Hurley had not yet began an at-home program or remote work program. So we had 100 plus employees in a open environment office. Obviously, with some of the risks involved with COVID and some of the education that was starting to come out, there were risks with staffing and that we had to address. So bottom line is we needed to recognize and accept that this was the first time for all, but things were coming pretty quickly in the first 20 days.
Yeah, that's amazing. Acacia, share what you guys saw over at Munson.
Sure. So, you know, for us, a lot of the same things that Mike just mentioned. I think we had a little more delayed schedule. I would say it was really that third week in March, more so the last full week of March, where we started to really start seeing those volumes declining. The stay-at-home order was executed in Michigan that week. And so I think that's really when our first 20 days started. Initially, we were looking to prepare for the surge. You know, our elective procedures started to be canceled. Ancillary departments started to close. And then additionally, as a system, we were looking at how best to serve that COVID population and where to do that from. So we established some regional COVID referral centers to, you know, both just take care of the PPE supply and demand and best treat our patients, both COVID-related patients and then, you know, non-COVID-related patients as well. Additionally, we were working diligently on off-site testing locations, so developing processes around that, making sure that we were trying to figure out, you know, what CMS and the payers were wanting as far as, you know, claims and diagnosis codes, making sure charges were built in the appropriate departments and locations across the system. Another focus was telehealth. We knew that we would have to really start ramping up our telehealth services that we were providing and, you know, just working with the clinical departments on who could offer those services, where we could offer them from, and more, you know, most importantly, how we could get that technology to patients and what insurance companies were going to be covering those services. Like Mike said, really a big focus on, you know, what the payers wanted. And even to this day, you know, we're still hearing from payers, oh, our system isn't, you know, ready to take that. Sorry, hold your claims. So really just trying to figure out, and it seemed like it's every other day, what the payers were looking for as far as claim submission and whether it be on a UB claim or a 1500, what modifiers and sequencing they wanted on some of that. And then I think lastly, just our staff. There was a lot of anxiety in those first few weeks. You know, schools were starting to close. We had staff who lost daycare services. We did already have some telecommuting programs in place and had staff working from home. So just refocusing on ramping up the volume of the staff there and making sure we were supporting them both from a work and home life balance.
Okay, that is, you know, quite an experience. And so we're going to move past the first 20 days. So now at this point and kind of our storyline here, we've got an understanding of what's happening, but no one really knows where this is headed. And to a certain degree, we still don't. But we'd like to talk about aligning teams and processes under a time of, you know, a ton of stress. So, Acacia, I think I'll let you take a crack at this one first, and then we'll hand it over to Mike.
Okay. So as far as aligning teams and processes, one of the first things that we did, like I said, we did already have a telecommuting program in place, and we had about 20% of our staff working from home when the pandemic hit northern Michigan. We very quickly, within the matter of a week, increased that remote workforce by 40%. So we now have over 60% of our staff working from home. There was, initially some concern from a management perspective regarding that huge increase in such a fast time period. We had some employees that we had concerns with low productivity and maybe some communication issues that we weren't sure would really be a good fit for that work from home environment. And so this really pushed us into allowing that, and, turned out to be really positive for both the employee and for us. And most of those folks are really just excelling from home and have really gotten into a groove now, 10, going on 11 weeks later. So that's been really positive. Additionally, not just the increased remote workforce, so those working from home, but we also had to remove 8 employees that were physically located within the hospital walls across our region and move them into our business office, which is located in Traverse City. There was obviously a huge focus on just keeping non-clinical employees out of the walls of the hospitals, to just keep a close eye on our PPE and the usage of that, as well as just, sharing people and visitor guidelines and just keeping anybody that's not needing care out of our hospital. So that was, one of those things that really increased staff anxiety as well for those who were affected by that. So they no longer were in the comfort of their homes working. They no longer were in the comfort of, their office space that they've been used to, but now having to move to a new office space. And for some of those folks, it meant an increased commute time to work as well. We also experienced some temporary furloughs on some of our teams, so that really, made us reevaluate our processes and cross-coverage situations. I think primarily our biggest teams affected by that were our customer service and financial counseling teams. Those folks historically were the ones who primarily worked within the setting of the hospital. So some of those folks transitioned home, and some of those folks transitioned into our business office. So not only do they, have to now go from face-to-face interaction with our patients to a virtual platform where they're making additional phone calls, sending applications for Medicaid or financial assistance through email or through fax or just through the post office. So lots of processes for that team that were changed. And then additionally, our customer service team is really the ones focused on our uninsured COVID population as well. So with the HRSA program and information that was just released in the last couple of weeks, they've really hit the ground, doing that manual deep dive into those uninsured COVID patients and making sure that we are submitting patient rosters for truly COVID-related cases. And as I'm sure most of you can appreciate, that's not the easiest thing to do, especially those patients who are coming in for COVID screening and, with those Z codes that are used for things other than COVID, really taking a really manual deep dive and reading records and making sure that we're submitting valid patient rosters to the HRSA program. So I think that's a lot of what we did as far as aligning our teams and processes in those early days and continue to work on today.
It's amazing how much you can get done in a short period of time when you have to. Like, wow, you just started thinking about all that. So Mike, what did you see on your side?
Well, I'm sure there's a lot of folks on the phone that are probably shaking their heads in agreement with Acacia in terms of some of their experiences, and I'm doing the same thing here because a lot of our team alignments, as an example, really were very challenging, particularly as it relates to trying to quickly adopt a work-from-home program. As I mentioned earlier, we in the revenue cycle had not yet experienced with the work from home program. We had a tentative plan in place to begin a pilot program starting in April. Well, the COVID really kind of forced us to do that much quicker than we were ready for. That tentative plan was only planned for about 20 employees. We now had to worry about 120 employees relative to those that we were now forced to send home based on the governor's order, as Acacia mentioned, on March 23rd. So we really were scrambling to try to figure out how do we do this. We had thought about it, we had some policies in place, but we had never experienced it. So for us, it was very new territory. We had concerns about our staff being unprepared. We had concerns about some staff being undisciplined to be able to work from home. Untrained, we had some new employees that still needed to be trained, and the best way to train is really face-to-face with your trainer. And we had low performers. So in terms of who do we send home in our primary preliminary pilot program, our plan was to only send home those that were proven effective, efficient workers. Going back to my comment about our union environment, that created some stir with our unions because their approach was we'll send people home based on seniority. So we obviously had some quick disagreements on that because some of our most senior employees are some of our most unproductive employees. So a lot of challenges that created for us. We quickly had to realize, though, that we were in a new world. We needed to adapt. We quickly realized as well that staff communication and activity monitoring became crucial for the management team. I think it's much easier to do that when they're sitting in front of you in an open environment with glass partitions that you can see what people are doing and interacting with people, but now we're in a new world of communication. So quickly adopted virtual huddles. We enabled chat options on the internet, so through our software program so they could chat with each other, management and supervision. We had to quickly allow for phone setups. We did have some operations that we were constantly on the phone with customers and payers, so we quickly had to work with our IT department to make sure that we had that phone set up in order to ensure that those sitting at home were notified when customer calls came in. Other challenges that we were faced with as we started moving people home or attempted to move people home, surprisingly, we still have employees without computers in their household. Similar to my comments I made earlier about the city of Flint and some of the lack of computers in households, I think at 30%. I have those individuals in my own operation. We've always adopted the dual monitor approach to our business in terms of requiring staff to have dual monitors on their desktop to be more efficient. That became a problem with people not having dual monitors in their household. We had some employees that had no internet. And then as Acacia mentioned, customer service was a major concern for us as we did not feel our phone systems were ready for a customer service remote operation. So those are issues that we quickly had to address relative to sending people home and the team alignments. Combined with that, again, as Acacia mentioned and as other organizations have gone through, we were in the midst of staffing reductions due to low census. Overall, we reduced our revenue cycle team by 18% through involuntary reductions, temporary reductions, a few layoffs, but most of them were furloughed for a period of time. As far as processes, our priority, again, in terms of managing the COVID onset of patients, was to quickly establish who those patients were so we could manage that population. With, again, the help of our IT department, we established billing indicators within our systems so we could identify every COVID patient, whether positive or negative, that came into our organization. We needed to do this in order to identify negative inventory trends. We were holding claims. We still are holding claims. We wanted to ensure timely billing. We felt that there was probably going to be some increase in denials coming forth as payers and providers start to figure out how to bill properly. Were we going to get proper payments? We've all heard about some of the payers that have stepped up and said that they will waive copays and self-pay obligations for patients. That's great, but does that mean the hospitals and the providers will get that extra funds, or will we not see anything at all relative to that? So we wanted to make sure that everything as we understood it was in order. And then finally, we needed to make sure that we were able to identify those self-pay uninsured patients that potentially will be covered through the uninsured reimbursement program that CMS has announced. So those are some of the things that we did relative to priority in terms of case identification. We needed to initiate new training and education for our staff. As both myself and Acacia have mentioned, telehealth, telemedicine was really becoming a hot item within the organization. Most of our coding staff had not had experience with the telehealth, plus we were seeing all kinds of new announcements and, relative to payer requirements and payer directions on that. So there was a whole new education that needed to occur within our coding operation to make sure staff were educated and aware as to what that needed to be. We had to assign, we reassigned staff based on low inventory. So if one person was performing in a particular area, such as an ER coder, where our ER volumes decreased by over 50%, we were now taking advantage of that staff member's expertise and moving them to other areas of our operation. It could be coding edits, claims that were denied for coding type issues, anything that we felt that we could take advantage of the expertise of that staff member that was now considered to be low inventory. And then we needed IT support for all this, obviously. I mean, these are all key things that, for the most part, had not been set up in our systems that we needed to react quickly to. So again, finally, just awaiting clear direction from the payers as to how we needed to change our processes and get claims in for timely reimbursement. Carol?
Wow, that's a lot. And when I hear what you and Acacia have presented, it just is clear that in a time of crisis, the focus, the execution, the clarity, because really the important things are really rising to the top. So it's super impressive how quickly you guys have pivoted, and I think it goes for the healthcare system overall in an industry that hasn't been known for traditionally moving super fast. So everything was turned on its ear, and it is amazing what folks can do when they're asked to step up to it. So thank you for sharing that so much. So now we're going to move on to rethinking strategies and goals. So we all spent the end of our last either calendar or fiscal year with plans and financial strategies and things that we were going to accomplish. We didn't see this coming, and so that impacted it, and just would like to hear thoughts on rethinking those strategies and goals and how you guys are going about it. So Mike, this time I'm going to start with you.
Yes, thank you. So rethinking goals, we are a June 30th hospital relative to our fiscal year close. So our goals were really important as we headed into the final quarter relative to our performance. And we were tracking very well with our AR goals, particularly in terms of meeting our objectives. In addition to obviously focusing on accounts receivable initiatives, we, like many organizations, had major projects on the table from the revenue cycle that we were working on. One of those being pricing transparency, which affects us all. Obviously, come January 1, 2021, where we're going to have to post our prices on the internet, that's a significant problem for most organizations in terms of meeting that. And a lot of work that has to go into that to achieve those timelines. So that was first and foremost on our list as far as projects that we were working on. Pricing strategy goes along with that. So we were looking at our ChargeMaster. We were looking at automated pricing within our OR supplies and Lawson system. So a lot of things that were on the table that essentially took a sidestep as far as what we could focus on, and our focus was completely on COVID over the last couple months. While we spent a lot of that time, as I mentioned earlier, looking at insurance operations and what we needed to do to get a claim into our payers, we quickly realized, based on calls that we were starting to receive from our customers, that we needed to kind of focus as well on our self-pay patients. Our board and our administration has been very, very proactive here at Hurley in terms of supporting our population and our demographics in terms of those in our community. Obviously, with some of the statistics that I mentioned earlier, we have a community in financial crisis in terms of their ability to pay. So we've done a lot of good things, we believe, in terms of supporting that, Starting in 2013, we put into place a presumptive eligibility program relative to co-insurance and deductibles and all the things that kind of come with some eligibility relative to charity care. So we have been very aggressive in terms of relieving patient bills automatically without the need for an application or without the need for a phone call. In 2014, 2015, we assessed our bad debt environment. Even though we've done a lot relative to charity care and providing that financial relief for those that were uninsured, we still have a large segment of our self-pay that are underinsured patients. We've got about 16,000 total self-pay accounts, and 75% of those accounts are cases where there's a insurance or a self-pay obligation after insurance. So we really kind of spent a lot of time trying to figure out how can we support our patients who now have a financial obligation. So in 2015, we partnered with Flywire in terms of creating a payment plan program. A lot of good things happened with that. As we go back and look at the statistic that I put out there relative to patients without internet, patients without a computer, we really felt that the product that we chose was really one that would help best in terms of our environment, our high incidence of Medicare. So we automatically offered payment plans on our statements with amounts clearly due indicated. Our initial focus when we went into this program was looking at bad debt patients where we had a history of payment plans being established by our bad debt agency, and we decided to bring those back in if we could. We also offered a 5% discount to patients if they paid in full in lieu of accepting the payment plan. But it really kind of said that's really kind of where we started, but as we got into COVID, we realized that maybe that wasn't good enough. As I mentioned, we started to hear calls from patients assessing that they were unable to comply with their payment plans that maybe they had already in place, or they could not comply with the fact that they no longer may have insurance due to unemployment. So one of the things that we did, again, partnering with Flywire in terms of making sure that we were able to do this from a leveraged system standpoint, we realized quickly that we were no longer just dealing with COVID patients. Much of our focus up to that point had been our COVID patients and making sure that we acted to that inventory of clients. But we're now dealing with not only COVID patients, but those in the community that were out of work, out of jobs, furloughed, whatever it might have been that caused their financial stress. So the first thing that we did is we decided as an organization, and again with support from our administration, that we shut off our bad debt referrals to our collection agency for a period of 60 to 90 days. As I mentioned, our June 30th fiscal year end, we will reassess this in the middle of June to see what the environment shows and make a decision as to whether we want to continue with that or not. In order to make sure that we complied with all the requirements of continuing to send statements to patients, we elected to delay or extend our pre-collect program. We have a vendor that supports us relative to pre-collect, and we extended that program from what normally would be a 45-day program to now what is a 90-day period. So every 30 days, patients will get statements. We turned to our patient cycle, our patient statement cycle, and our payment plan program. We worked with, again, Flywire to come up with some creative things that we felt really were beneficial. The first thing we did is we created a special COVID statement that went on the patient statement or a message, just letting the patients know that we care, we're aware of the financial stress. So that was one of the first things we did. We then looked at our payment plans and decided that could we do anything more for what we were already doing. Our average payment plan at the time was $71 per month. We have over 1,400 patients that are on our payment plan programs. One of the things that we decided to do to help reduce the stress was we reduced the option. We gave the patient an option to reduce their payment plan by up to 90% or $25, whichever was greater. So the fact that most of our patients are in that average $71 range as far as their payment plan amount, we typically would reduce those balances down to 25%. So that program was offered. We've extended it. We offered to extend it, and we'll extend it for 6 months through the end of October, and again, we will reevaluate it at that point. And then the final thing that we did was we extended the default on our payment plans. Typically under our program, you have 60 days to make your payment good relative. If you miss the first month, we give you the second month. We've extended that another 30 days. So in all, the patient now has 90 days to make sure that their payments are instituted and online with us. So those are the things that we did, and we'll evaluate all those as we go forward, but those are some short-term things that we felt really kind of helped our patients in a time of need.
Yep, that's great. Thanks, Mike. Acacia, how about you guys in terms of strategies and goals?
So one of the first things that we did, Carol, was really just put an increased focus on our metrics. We were already struggling to hit some of our normal goals for the Patient Financial Services Department for our fiscal year that will end June 30th. We've had some experiences with significant payer issues throughout really this entire fiscal year that has really created a backlog for us. And we, like I said, we were already kind of struggling to work through that. So we went from really a weekly review of some of our key performance metrics, such as AR days and our aging percentages, cash flow, cash posted revenue, and really started looking at that deep level at a daily review. We were looking more closely at our work queues, making sure that we are really keeping an eye and a focus on that aged work to ensure that we could capture anything, that had been sitting out there for a little while untouched, and making sure we could bring in every dollar that we could. Additionally, looking at some of those low dollar accounts, oftentimes those are ones that kind of sit on those work queues and in those lists a little bit longer as they're overpopulated by the larger dollar accounts sometimes. So making sure that we were really prioritizing both the old work and then the low dollar work more than ever before. Additionally, we had recently updated our financial assistance policy to include that underinsured population. Like Mike said, we have, quite a few patients who have that self-pay after insurance situation that we're going to bad debt or we're struggling to pay their bills. So we really just took a look at that policy that we had just put in place and made sure that our staff were prepared for that extra volume of applications coming in, additionally to the COVID population as well. And then lastly, around metrics and goals that we were working on, we have been working on a business plan to move 3 of our hospitals onto a lockbox platform, and we were hoping to do that in July of this year. And, probably about 2 weeks ago, we started rethinking that, reevaluating our financial situation across the system, and knew that it might not be the best time to pursue that. So just this week, unfortunately, we've kind of had to put a halt to some of that work, and we'll reevaluate that kind of after the COVID pandemic has settled down a bit. So disappointing that kind of happened in line with that. As you can imagine, having a lockbox platform, it just increases a ton of efficiencies for our department, but it's just not the best time for that. So that project has been kind of put on stand hold as well. Like I said, we had a heightened focus on a denials management, work. We had been really gaining momentum prior to the COVID pandemic and getting some executive leadership on a formal denials management team and getting some support from our senior leaders and C-suite. That unfortunately, has kind of slowed down, and what we've done during the pandemic, though, is taken some of those employees with maybe new reduced workloads and some of those who could have potentially been temporary furloughed and just move them to a denials focus. So taking folks across our revenue cycle teams and really having them deep dive into some of those denials and that follow-up work from the insurance companies. We also looked at how best to support our patients virtually. So we started receiving phone calls from patients even early in March, really before this stay-at-home order was in place and business started shutting down. I think just patients could kind of see nationally what was going on and learning from things that were happening over in China and other countries. And, they were just calling and saying, hey, I'm worried about my job, not really asking for us to make a change immediately that day, but just kind of feeling Munson Healthcare out for the stance that we would take in assisting our patients through the COVID pandemic. And so what we've done is, over the past couple of months, really worked one-on-one with our patients as they're calling in or as they're getting a hold of our customer service team to look at their financial situation, review with them if they're expecting this to be kind of a temporary financial burden to them, or if they were foreseeing, more of a permanent layoff maybe from their business or from their place of work. So just working with them one-on-one and making those phone calls with them and those contacts. We deferred some patient payments for a month, sometimes two. A lot of patients, though, were calling and just saying, hey, can I make a $10 payment just to avoid that deferment or avoid going to collections. We waived our monthly service fee on any payment plans for patients that needed us to do that. And then also just assisting them with those Medicaid and financial assistance applications when needed. And that needed to be done now virtually through phone calls, obviously, but just making sure that our patients felt supported and knew that, we were appreciative and understanding of where they were at in their financial health as well, and doing whatever we could to assist them with that burden. And then I think lastly, just a new focus on our staff and supporting them in their new environments, whether they were working in a new office setting or maybe now they were working from home. Some of them might have kids home with them. Some of them might have kids home and trying to help with schooling at the same time. So just really, supporting them, offering flex schedules, increasing our team huddles that we were having with them, increase those individual touch bases via phone calls where, you can't just have an employee standing in your door when they need, you need a question answered or just want to kind of give you an update on their personal life, just increasing those touch bases with them so they felt supported. And then I think, too, we had a pretty significant turnover over the last year in some of our billing teams, and so we had a lot of new employees who were just recently onboarded in the last few months. So supporting them and making sure they were comfortable now with their virtual training. Usually with a new employee, we really like to give them a good solid 6 months, maybe even a year of physical support with their leads and managers on site. And so this is a new world both for our coordinators and these new employees. So just making sure that they felt supported and made sure that they were getting the education they needed.
Yeah, that's great. And I think the new world, we won't be going back. So thanks you guys both for those insights. Again, so much going on and you guys just figuring it out as you go. So that's amazing. We're getting a little tight on time, and I know that there's some questions out there. So we'll I think the team has folded into their conversations about leveraging technology and how important that is. And interesting watching the Hurley team very overtly message and have things on their website using tools to digitally help them deliver. The Munson team had a more personal one-on-one approach, but yet in the background, the technology was taking those minimum payments and not advancing and not aging. So I'm going to share a slide here. And, I don't have time to go through these, but I did want to just share with the audience a bit of, what many of our clients did in terms of, changing those cycles, and then also the statement messaging. Some clients did inserts. We introduced a COVID-19 chatbot that we worked with Ivy to create that they were kind enough to put out at no charge through June. And so lots of communication and lots of cycle changes in terms of not having patients go to bad debt, and just the compassion that our clients have across the board has been really amazing. So before we move to kind of our final thing, did Acacia or Mike, did you have anything else that you wanted to add from a technology perspective?
No, I think you've, I think I would agree.
We're good.
Thank
you. Okay, so we will move on to, key takeaways and predictions for post-COVID. So Acacia, how about we start with you, and then we'll hand it over to Mike, and then we'll see if we can squeak out a few questions here in the last 2 minutes.
Okay, sounds good. I'll try to go through some of these points pretty quickly. Biggest thing for me, number one, is really just how exciting it is to see how, as a system, we have come together, and I just feel like we are stronger now than we've ever been. We do not have a formal revenue integrity team here for Munson Healthcare, even though we are a system. Like I said a little bit ago, it's one of the goals that we were working on and really getting some focus to denials management and revenue integrity. But through COVID, it's really pushed us to work better together. So, clinical teams, our coding team, billing team, finance team, compliance, all really had to come together and, figure out these payer regulations and figure out where and when we needed charges built and used. So that's really been exciting, and I'm really just looking forward to how that collaborative effort will continue into the future. Second, I think that we're going to see the effects of cleanup from COVID claims for months, if not years to come. Like we've talked about, some of those payers are still to this day are coming in and saying, oh, by the way, our system can't accept your claim. Please hold, or, Medicare themselves we will reprocess sometime in July. There's also a lot of unknowns still around that HRSA uninsured patient population and how those are going to come back to us, how they'll be vouchered, and what that's going to look like. So I think that we'll just be experiencing COVID for a while now in getting those claims cleaned up. Third, I think just, it seems like we've got increased engagement from our patients, and they're becoming a little more comfortable with technology. So I'm really excited to see how we use additional avenues in the future. We've kind of talked about robots and chatbots, and so I'm just really looking forward to what this pandemic has pushed us all into as far as technology goes for our patients and for our staff. That's just lastly I'll wrap up with, we had a lot of, I personally had some managers on my team who were not as excited about the work from home and environment, and we were still requiring folks to come on site even a day or two a week just for that face-to-face interaction and team bonding. And I think that this has really just pushed us all out of our comfort zones, and the work from home environment is possible in healthcare. And so I'm just really excited about what that's going to do for our new normal and possibly some opportunity for cost savings for our healthcare system.
Yep, amazing. Mike, rapid fire here.
Yeah, very, very similar to Acacia's comments. I think number one is the uncertainty of accounts receivable management. I would agree that we're looking at months ahead as far as cleanup and recovery of the AR for COVID type patients. We haven't yet seen denials that I think we're going to start seeing quickly in terms of what might not be passing payer edits and so forth. So the other question would be underpayments. Are we going to get what we expect relative to expected reimbursement? Number two is working from home. As, again, Acacia mentioned, I think is a new norm. It's really kind of changed the eyes of my administration and myself, really, in terms of what we can do. I think our employees have really surprised us. We have seen an increase in productivity during the first month of about 9%. We're hoping that continues to increase and continues to be an increase over what we saw in the office, but that's going to be a challenge going forward. It clearly has provided us an opportunity to reduce some significant lease expense that we're currently paying for our office location. So something that we're seriously looking at. And then finally, the approach that we took with our patients relative to financial relief, I think, is really rewarding as we start seeing some of the early returns on patients who have accepted our offer for reduced payments. I think that's something that we're really proud of. It shows our concern, our compassion for the community that we live in. So really happy with that. We have had some concerns with that relative to, we have seen an increase in the plans that have been canceled. Not a significant increase. We averaged about 15 accounts per hour. Now we're up to 15 accounts total per month, and we've seen that increase to 30. So not a significant increase over 1,400 accounts, but we need to be attentive to those and figure out what we can do to help those patients. And I think finally, the fact that we've all stepped up and worked as a team throughout our organization with the payers has really been rewarding. So those are my key takeaways. Thank you.
Awesome. Okay, great. Well, we're right up to the top of the hour, and I'm not sure if the Becker's team will allow us. I know we've got some amazing questions out there. If there's a little bit of time that we can go over, Daniel, do we have that, or do we need to wrap it up?
Hi, Carol. So, yeah, unfortunately, we did run out of time, but to all of our attendees, I do want to let you know we have all of your questions queued up, so we will be sure to have our presenters be able to follow up with you and get answers to all of your questions and connect there. But I do want to thank Mike and Acacia for their excellent presentation. Thank you so much, Carol, for moderating for us. And thank you also to Flywire for sponsoring today's webinar. Hope everyone enjoys the rest of your day. We look forward to having you for future webinars.
Hey, and Daniel, I'd just like to add that I'd like to thank, everyone in this industry for working tirelessly on revenue cycle. It's really mission-centric, and without these teams, the hospitals really can't deliver the amazing clinical experiences the patient has. So just shout out to all the teams working diligently to overcome these obstacles.
Absolutely.
So thanks to everybody.
Thank you.
Have a great rest of your day.